This will be the continuation of your discussion on diabetes. In this lecture, we'll be discussing about the acute complications of diabetes. So take note that there are acute and chronic complications for diabetes. In this discussion, our focus will be the acute, meaning the more emergent one. Now, let's talk about your diabetic ketoacidosis. Okay, take note, diabetic ketoacidosis. Diabetic ketoacidosis develops when there is insufficient insulin that results in cellular starvation and hyperglycemia. The key word here is insufficient insulin. This would differentiate your diabetic ketoacidosis to the other acute complication that we will be talking about. Now, if you would look at this pathophysiology, this was actually derived from the book of Saunders. Okay, the triggers for your diabetic ketoacidosis would include your infection and stress, which would result to excess secretion of glycogen and other counter-regulatory hormones. Okay, so that secretion of glycogen is made possible by glycogenolysis and your gluconeogenesis. So recall that when I talk about glycogenolysis, this is glycogen being broken down, to glucose, and your gluconeogenesis is the formation of your glucose from amino acids. So that's not the usual process that our body would be doing. And because of that, there is an increased lipolysis of adipose tissues. Okay, so this is not the usual source of glucose, hence the body would find it insufficient. Our body would still be looking for fats as a source of energy. And because of that, you have your ketogenesis, which leads to ketosis and later on acidosis. Okay, that's why the problem here of our patient is referred to as ketoacidosis. If you look at the other side of the diagram, okay, this is also a trigger of your DKA would be a missed insulin dose for new onset diabetes. So take note that the role of your insulin is not only to decrease your blood sugar or to metabolize your blood sugar to be used by the energy or for its energy to be used by the body, but it is also used to stop the breakdown of your fats, okay, to stop the breakdown of your fats to prevent the formation of ketones. So if your patient would miss an insulin dose, that would indicate there is an inadequate dose, there is decreased glucose uptake, okay? Despite the decreased glucose uptake, because of the counter-regulatory measures that are being done by our body, glycogenolysis and gluconeogenesis, there will still be an increase of your blood sugar. Okay, a compensatory increase of your blood sugar. Then you have your osmotic diuresis, and then because of your osmotic diuresis, you have your potassium loss. Okay, so how does osmotic diuresis occur? Due to the increased concentration of the blood sugar in the blood, and also because of the acidic state of the blood, okay, your body is trying to excrete the acid through the kidney, the acid and then the excess sugar of the body. So it's being excreted through your kidney in a process that we refer to as osmotic diuresis. So recall your osmotic diuresis is the movement, okay, of your solute from an area of low concentration to an area of higher concentration. Movement of solvent, for that matter. And then there will be potassium loss. That's why for that reason, okay, your potassium, okay, your hypokalemia is also a common complication of your diabetic ketoacidosis. And then later on, your patient would manifest with dehydration. So take note, those items marked by an asterisk because these are the hallmark presentation of your diabetic ketoacidosis. Okay, so you have your ketosis, you have your acidosis, then you have your hyperglycemia, and then dehydration. Okay, if you would look at these signs and symptoms, you picture a patient being admitted in the ICU, okay, because of these signs and symptoms. Okay, picture a patient that could be intubated because of severe acidosis. Okay, now ketosis. How would we know that there is ketosis? The ketone might come out in the urine, so the urine may test positive for ketones. Acidosis, we need your ABG result to confirm that. Hyperglycemia, okay, the result of the blood sugar will be high. And then, of course, dehydration, you'll be looking at the signs and symptoms of fluid volume deficit. Okay, again, I would like you to look at the triggers of DKA. So you have your infection and stress. What is it in infection and stress that could increase the risk for DKA? Your infection and stress are both stresses on our body. Okay? It increases the demand of our body for glucose, meaning your body will seek more glucose because it attempts to heal its body. Okay? For that reason, higher glucose demand. And then miss insulin dose. Without insulin, again, fat would metabolize. Okay, so again, that's your diabetic ketoacidosis. Now, Etiology, as mentioned, omitting dose of insulin, too little insulin. Okay? So, if your patient is not responding to insulin therapy within the time set by the physician, they need to return to the healthcare provider for the re-evaluation of therapy. Maybe they need to increase their insulin, or they may need to explore the use of other types of insulin. That's why for that reason you have your insulin pens, which would have the combination of different insulins with different onset of action. Then, sometimes it also occurs because of the failure to meet the increased need for insulin. So the increased need for insulin, as mentioned on the previous slide, could be because of infection, it could be because of stress. Okay, we are adding here surgery, trauma, pregnancy, and puberty. These conditions would need to have increased insulin. Now you might be wondering, puberty, how come a puberty or a patient who is just an adolescent undergoing adolescence would have diabetes or would have DKA? Okay? Now, if you would look at the definition of DKA, there is an absence or total lack of insulin. Okay? With that definition, what type of diabetes do you think are we exploring here? Yes, we are already thinking of type 1 diabetes. And then when I said about type 1 diabetes, I mentioned to you that your type 1 diabetes would have more of familial implications compared to your lifestyle and dietary implications. Okay, so that's why it's usually referred to also as juvenile diabetes because it is diagnosed at the early age. Then, undiagnosed diabetes. So your patient might not know that they have diabetes, and because of that, glucose imbalance, insulin imbalances. Okay, hence you have your DKA. Then, diagnostic studies. Look at the range of the blood glucose. So for your DKA, your blood glucose will be playing at 300 to 800 milligram per DL. Okay, or it's even increase. In ketoacidosis, you would notice the bicarbonate to be decreased. Okay, the pH would also be decreased. For the PCO2, it would depend on the compensation of the patient. If the patient will be able to compensate, your heart or your lungs, will attempt to excrete carbon dioxide in an attempt to reduce the acid in our body. However, if your lungs is already failing, your carbon dioxide may also be increased. As I have mentioned, there will be also presence of ketones in the urine. Your electrolytes will be imbalanced, particularly we're talking about potassium. And then particular complication of your potassium will be your hypokalemia. Furthermore, our creatinine, BUN, and hematocrit will be increased. The increase of your creatinine and BUN is because of the damage to your kidneys brought about by your metabolic acidosis. Also, take note that with these high levels of glucose, your patient may be already experiencing diabetic nephropathy, which is the damage on your glomerulus and the damage also on the small blood vessels of your kidney brought about by the increased blood sugar levels. Your hematocrit is increased because of hemoconcentration. Okay, because of the high concentration of ketones that you have, the high concentrations also of glucose that you have. And take note that one problem that is occurring in diabetic ketoacidosis is that there is prominence of your osmotic diuresis, meaning your patient is also experiencing signs and symptoms of dehydration. So recall that your hematocrit is the measure of concentration of our blood. So whenever there is an increase of hematocrit, that would indicate that there is an increase in the proportion of solute in comparison to the fluid available in our bloodstream. That's why your patient is having increased hematocrit levels. Now, the blood glucose would be increased. Of course, you have seen the result 300 to 800. So other than the 3 Ps, your patient would have blurring of vision, signs and symptoms of weakness, and then also your headache. There will also be a decrease of fluid volume. So dehydration, as I have mentioned earlier. So because of that, your patient will be experiencing signs and symptoms of orthostatic hypotension. Then there could be frank hypotension with weak or steady pulse. So as you can see, the compensatory mechanisms of the body are already failing in your diabetic ketoacidosis. Then you have ketosis and acidosis. So with this, GI symptoms will become prominent. Anorexia, nausea, vomiting, and abdominal pain. Now, the acetone breath there is related to the increase of ketones in the bloodstream. So take note, your ketone is that of the same family of your acetone. Then your Kussmaul's respiration, or your deep breathing, or your irregularly rapid breathing, for your Kussmaul's respiration, is because of the attempt of the body to excrete the excess carbon dioxide, okay, the excess carbon dioxide, which increases the acid levels in our body. So because there is a lot of acid and the kidney is being damaged already, your lungs would try to compensate. Remember, if our problem is metabolic acidosis, your kidney may be working hard, but it is your lungs that will be compensating. So to compensate, your lungs will try to excrete carbon dioxide. That's to balance the acid in our body. So in that case, it would manifest as Kussmaul's respiration. Then changes in mental status because of the increase of ketones, dehydration, osmotic diuresis, okay, all those factors combined, your patient will have changes in mental status. So your patient may be alert at first, later on he will progress towards lethargy, okay, become obtunded, stuporous, then later on coma. That's why if your patient has diabetic ketoacidosis, it is very important for us to continuously assess for the neurologic status of our patients. Then, therapeutic management. What will be your role here in diabetic ketoacidosis? One is insulin replacement. Remember, there is a lack of insulin. So you need to do insulin replacement. You need high doses of insulin for this one. Then, rehydration. So you need to rehydrate your patient. You'll be giving plain NSS to your patient at the rapid rate, and then 0.5 to 1 liter per hour times 2 to 3 hours. So meaning it's a rapid infusion of your plain NSS. Okay, you may give 0.45% of normal saline. Then later on, it is decreased to 200 to 500 ml per hour until the BP of your patient would become stable. Okay, so if you can notice, there's a rapid replacement of fluids that's occurring to our patient. The next management that we would have is the administration of your D5 water. Now think, we are dealing with a patient with diabetes, but we are administering D5 water. Okay, that could be ironical because your patient with diabetes, supposedly, our goal is to decrease their blood sugar levels. But take note, we are talking here about acute complications of diabetes. So if we are dealing with a patient with diabetic ketoacidosis, it would warrant the administration of your D5 water. Okay, so take note that your D5 water, once it enters the body, it becomes isotonic because the body would be able to metabolize your dextrose 5 already. Okay, and your D5 will be available as the supply of glucose of our body. In this case, class, okay, your D5 water is used if your blood glucose level is less than 300 milligram per DL or less. Okay, so take note, in diabetic ketoacidosis, our glucose may run as far as 300 to 800 milligram per DL. But if it will be 300 or less, we need to balance it with D5 water. In other words, we do not want an abrupt decrease of the value of our glucose levels. Now, the purpose of your blood glucose administration is to prevent hypoglycemia or cerebral edema. Now, the question is, how can cerebral edema possibly occur when your patient is hypoglycemic? Okay, you try to find out what could be the reason or what is the underlying physiology. How can hypoglycemia cause cerebral edema? Is it also possible to be caused by your hyperglycemia? Okay, and if it is hyperglycemia, how can hyperglycemia, if it can, produce your cerebral edema? So take note, when I say cerebral edema, that would lead to the increase of your intracranial pressure. And the increase of your intracranial pressure could possibly manifest as signs and symptoms like that of your stroke. So your patient will have altered level of consciousness, okay, due to increased intracranial pressure. Then, we give your electrolyte replacement. Recall earlier that one of the electrolyte imbalance common in DKA is your hypokalemia. So you need to monitor the serum potassium every 2 to 4 hours. Since we're talking about potassium, you need to monitor the ECG of your patient. Okay? Since remember, your potassium would be acting on the heart of your patient. Hold the replacement if patient is unable to void. What do you mean by that? Remember that your potassium is primarily excreted through the kidneys. Okay? So you do not know what will be the incoming mechanism of your body. Hence, if your patient is not voiding, your patient will be at risk for hyperkalemia. Okay? It should be done with caution because depletion is rapid due to rehydration and insulin administration. Okay? Remember, in diabetes, ketoacidosis, DKA, we manage also with insulin. But with the management of insulin, recall that your insulin would also decrease your blood potassium levels. Okay, so for that reason, it could be that the patient is having hypokalemia because of the DKA osmotic diuretic, and also your patient is having hypokalemia secondary to treatment. That's why potassium levels is closely monitored. Then insulin replacement. Okay, this time it's indicated for to reverse your acidosis. Your regular insulin could be given IVTP or slow infusion and at continuous rate of 1 unit per 5 ml. Okay, in such a way that we can administer 5 units per hour of regular insulin. Okay, to commensurate with the ml per hour rate of your IVF fluid. Okay, so class, remember the only IV or the only insulin that could be administered IV is your regular insulin. So it is a clear type of insulin. The other types of insulin could not be given IV. So in this case, class, it is also incorporated to your IV fluid, and that incorporation is to maintain a basal rate of your insulin production, okay, or your insulin supply, I mean. Then, if the blood glucose is already at 250 to 250 to 300, milligram per deciliter, you can change the IV to D5-NSS or D545% NSS to prevent hypoglycemia. So this one is already containing your D5, okay, D5 dextrose. So just like your D5 water earlier. So from this, we can deduce that if your patient is having blood sugar levels of 300 and below, for a patient with DKA, we already start your D5 containing fluids. Okay? Plus, in this case, your insulin replacement could be incorporated on the D5. So you might be wondering why incorporate insulin in a dextrose. It's just like you're increasing the blood sugar but planning to decrease also the blood sugar. Again, class, we would like to balance the sugar. Okay? We don't want our patient to have an abrupt decrease of your blood sugar. On the same way, we do not want your patient also to have zero insulin because your patient's ketones or your patient's fats may be metabolized. Now, the next complication that we'll be talking about is your hyperglycemic, hyperosmolar, non-ketotic coma. Okay? Hyperglycemic, hyperosmolar, non-ketotic coma. Okay? Remember the term, hyperglycemia. There is an increase of blood sugar. Hyperosmolar, there is an increase of osmolality. Non-ketotic coma. Non-ketotic, meaning there is no ketones in the body. However, there is also coma. Okay? Now, it's coma condition, wherein insulin is sufficient to prevent the ketone bodies from forming, but still it's inadequate to reduce your hyperglycemia. This condition is characterized by the presence of your extreme hyperglycemia. The patient would have blood sugar levels of 600 to 2000 milligram per DL. If you are using your glucometer to a patient class, for example, with HHNC, your glucometer would just read too high. Okay, because your glucometer, some of the glucometers is unable to read values above 600. Other glucometers could not read values above 800. So it would just manifest as too high. So if your patient is comatose and then your patient is manifesting with that glucometer too high class, you need to suspect that there is HHNC. Assessment findings for a patient with HHNC. So class, your patient would have the same signs and symptoms as your diabetic ketoacidosis, except that, okay, there is rapid coma. Also, class, ketone is low or absent, unlike in your DKA wherein the ketones is high. And then class, there will be no Kussmaul's respiration. Unlike in your DKA, we have your Kussmaul's respiration. Then the acetone breathing class would be negative because take note, we don't have an increase of acetone levels here. Okay, your patient would also have hypotension, profound dehydration. There is tachycardia class. Okay, take note that in your DKA, it's weak intraday pulse. Then you have your neurologic signs and symptoms also to be present. So remember, it manifests also as coma. Then, medical management. So here we're talking about your rehydration. So we are still using your plain NSS or 0.45% NSS. Still, we are talking about electrolyte replacement. So potassium replacement is still prominent management for this one. Your insulin replacement is also given, but it is done at a very low rate. Okay? Now, class, I would like to have a comparison between your DKA and your HHNC. Okay? I would like to give credit again to the Book of Saunders for this summary. Now, class, your DKA, okay, onset. So, the onset of your DKA is sudden. Compared to your HHNC, the onset of which is gradual. The precipitating factors, okay, are related to infection and stress. Okay, for your DKA, it's usually the inadequate insulin dose. For your HHNC, it is also related to your poor fluid intake. Okay, but for the manifestations class, okay, the main difference there would be that one. Okay, in your DKA class, your patient is manifesting with ketosis. There is Kussmaul's breathing. The breathing may be fruity. Plus, the fruity breathing is related to the increase of your blood sugar levels. Then you have the nausea, abdominal pain, which is related to your ketosis. Okay, both would have altered CNS functioning. Then, for the serum glucose, if you have noticed earlier, for your DKA class, okay, it's playing from 300 to 800. But for your HHNC, it may be playing between 600 to 2000. So if you would look at the two class, the increase, your hyperosmolar, hyperglycemic, non-ketotic coma would have higher levels of glucose. For the osmolarity class, for the DKA, it may be variable, but for your HHNC, it's always increased. Remember the term hyperosmolar. For your DKA, ketoacidosis, of course, that would be present in your ketones would be present in your DKA. Okay? Class acidosis would be present on a patient with DKA, but for a patient with HHNC class, oftentimes the patient would have alkalosis. Okay, as you can notice, that is commensurate also or congruent to the values of bicarbonate here. Okay, you can notice, class, if your patient has DKA, the bicarbonate levels would be decreased. In HHNC class, the bicarbonate levels would be increased. Again, I would like to correct that. In DKA, your bicarbonate levels is decreased, and then in your HHNC, bicarbonate levels is increased. So serum potassium. In DKA, your serum potassium may be normal. It may be increased or decreased. So in acidosis, the tendency of your potassium is to be increased. Okay, how would that be? Recall that if your patient is acidotic, there is an increase of your hydrogen ion concentration. And your body would try to compensate that acidotic state. What would your body try to do? So your body would try to move the positively charged hydrogen ions inside the cell in such a way that it would be decreased outside the cell. Now, in an attempt of your body to move the hydrogen ions from the outside to inside of the cell, the potassium would be going out of the cell. Okay? Because they're both positively charged, so the tendency is that for them to exchange. For that reason, patient with acidosis will have your hyperkalemia. But if your patient is dehydrated, especially if I'm talking about osmotic diuresis, wherein potassium also goes out with the urine of your patient class, okay, the tendency is that the potassium levels will be decreased. In HHNC, your potassium levels may be normal, it may be low. In your BUN and creatinine, so signaling kidney damage or kidney overload class, the condition would lead to an increase of your BUN and creatinine. Another complication that can possibly occur in our patient with diabetes is your hypoglycemia. Okay, so you have your hypoglycemia, or what we commonly refer to as your insulin shock. Now, etiology. This may be because of overdosage of insulin. This may also be brought about by omitting a meal while on insulin or your oral hypoglycemic agent. So class, that's why we educate our patient that if ever they're taking their insulin, they're taking their OHA, skipping their meals is not a good idea. Okay, it leads to hypoglycemia. Also, it could be characterized by overexertion, meaning your patient is having a lot of activities without additional carbohydrate compensation. Also, it could be your nutritional and fluid imbalance and then your alcohol intake. So, class, your alcohol intake increases the resistance to insulin, which leads to increase of your blood sugar levels. Then, there is the mild symptoms of your hypoglycemia. Your patient would have sweating, Okay, there will be tremor, tachycardia, palpitation. They would have signs of nervousness and then hunger. Okay, class, hunger is usually the first indication of your decrease of carbohydrates or decrease of glucose. So if the level, class, is low, let's say for example 70 milligram per deciliter, a sugar-containing food should be eaten right away. So class, we educate our patient that if they are into insulin, they need to carry the rescue candy, okay, a candy which is rich in sugar, class, in such a way that if they are feeling signs of hypoglycemia, they need to take this candy right away for their blood sugar levels to recover. Now, moderate hypoglycemia. For your moderate hypoglycemia, this is characterized by inability to concentrate. Also characterized by headache, lightheadedness, and confusion. Okay, also brought about by numbness of the lips and tongue, slurred speech, impaired coordination, and emotional changes. So as you can see, your patient is already manifesting with signs and symptoms of neurologic deficit. Because remember, glucose is the main food of our brain. So for that reason, if there's decrease of glucose levels, your patient will have confusion. Okay, and other signs and symptoms mentioned here. Also, your patient may have irrational or combative behavior. That's why you can notice, class, there are patients who would be engaged on arguments, okay, because of decreased blood glucose levels. Okay, double vision is there. And then drowsiness is already a signal that the brain cells are being deprived of glucose. Then for severe, the patient may be disoriented already, does not know time, place, person, and purpose. Your patient may have seizure. Your patient will have difficulty arousing from sleep or loss of consciousness. So you'll have the progression from lethargy, obtunded, then you have stupor and coma. Signs of CNS impairment already. Medical management. So we need to have an immediate treatment here. 15 grams of fast-acting concentrated carbohydrates is needed. Okay, fast-acting concentrated sugar is needed. Glucagon, 1 milligram sub-Q or IM is given. If the patient is unconscious or cannot swallow, you do not give your sugar. Okay, you might need to administer 50 ml of dextrose 50 in water. Plus, your 50 ml D50 water is a bit of, let's say, a thick fluid. It's clear, but it's a bit thick. So, class, we usually use your large bore needle, and then we use your big syringes, a 50 ml syringe, to administer this one. Okay, then, usually, if they're in the US setting, usually advised to have their ID bracelet, okay, to indicate that they have hypoglycemia, risk for hypoglycemia. So the bracelet would indicate that they have diabetes. Also, class, you need to have sugar source, such as your glucose tablets or raisins. Now, let's talk about the long-term complications of diabetes. So you have your macrovascular complications. The macrovascular complications would include your CAD, your CVD, and then your PVD. CAD, coronary artery disease. You have your cardiovascular disease, and then your peripheral vascular diseases. So you also have your microvascular complications. So microvasculature, meaning it involves smaller blood vessels. In that case, you have your diabetic retinopathy. Your diabetic retinopathy would first manifest as a sign of blurring of vision. And then your patient later on, if not managed, would have signs of blindness. Then you also have your diabetic nephropathy. So in your diabetic nephropathy, it may lead to your end-stage renal disease. You also have your diabetic neuropathy. Your diabetic neuropathy could be peripheral and autonomic. So you have peripheral and autonomic neuropathies. So in peripheral neuropathies, that usually affects your peripheral aspects of your body. That would include your finger, that would include your toes. So that's why your patient would have foot and leg problem, because the tendency is that they are unable to feel or properly sense pain and other stimuli on the peripheral aspect of the body. Then there could also be foot and leg problem. Okay, so the foot and leg problem, as I mentioned, is due to neuropathy. So due to the impaired sensation of your patient, they are unable to feel if there is a itchiness. Okay, for the same reason, also your patients with diabetes are at increased risk of having burns secondary to a simple hot water bag application, because they are unable to feel pain whenever they are exposed to high temperatures. And then you have your peripheral vascular diseases, and then you have your immune compromise. So the compromise of your immune system is related to two factors. Okay, one, there is an increase of sugar levels, which is a favorite site or growth medium of your infection, and then added to that, okay, the damage on the microvasculature would decrease the amount of white blood cells and immune responses that would be going on the peripheral aspect of the body. So, foot care. Diabetic foot is a very common complication of diabetes. So, diabetic foot, we're just talking about a simple wound on the toe of your patient or maybe on the foot of your patient, and then later on leading towards gangrene, and then later on you'll know that your patient would have a below the knee or above the knee amputation. Okay, so that's how severe it could get. So you advise your patient to bathe properly, dry and lubricate properly that area. So when I say dry, that would involve cleaning the spaces in between the toenails, okay, between the toes, I mean. Then they should wear closed-toe shoes that fit well, so it should be well fitted. It should be closed in such a way that it will not be wounded whenever they are walking. They should trim the toenails straight across and then file sharp corners. Okay, you don't want ingrown to be occurring on your patient with diabetes. If your patient would have ingrown, the tendency will become diabetic foot infection, gangrene, amputation will be the sequelae. Then reduce or stop smoking. Remember, they are at risk for peripheral vascular diseases. Recall the two peripheral vascular diseases that we had discussed last semester. So you have your Berger's disease and then your Raynaud's disease. So for your Berger's and Raynaud's, one of the risk factor is smoking. So if you don't want this condition to be aggravated, smoking should be stopped. Okay, it says the reduce because initially you would be reducing it because you could not stop smoking abruptly. Then avoid home remedies. Over-the-counter medications is a no-no in diabetes. Herbal medications is also a big no-no because we do not know how will they be interacting on the blood sugar levels, and we also don't know how will they interact with the oral hypoglycemic agents that we are using for our patients. Added to that, so class, this is a picture of diabetic foot. So initially, your patient might not be able to feel anything there. Okay, it would just appear as an area of redness. And then later on, your patient may report to you in the clinic and would say that they have a non-healing wound. Let's say, for example, for about 4 weeks already. Okay, that's the usual complaint that they do when they even present in the ER. So class, don't say that this wound is dry, it's healing. So it's not. Okay, a normal wound could heal within a week. Okay, you would see a regression on the size of the wound. But on their case class, you will see that there is progression on the size of the wound. So the tendency is that it becomes an ulceration. So it penetrates deeply through the tissues in such a way that the blood vessels of the patient will already be damaged. So with that damage to the blood vessels, that's the reason, class, that even if the wound could only be found on the ankle, oftentimes we opt for a below-the-knee amputation because the vasculature or the blood vessels internally are already affected up to the level of your knee, for example. Okay, so that's why below-the-knee amputation is often recommended. Then, this is a gangrenous foot already. Okay, if you would look at it, okay, there is already necrosis. The yellowish area there are deposits of your pus. So we usually get tissue culture here, okay, culture for identification of the bacteria or pathogen for that matter. Okay, so you can see the progression, okay, or the healing on that one. Okay. Then we recommend our patients to use self-examination mirror. That is for them to see the dorsal aspect of their foot, okay, or their feet for that matter, because wound may be there, but they are unable to feel it. So surgical care of a client with diabetes mellitus. Preoperative care is, your goal is that there will be a regulation of blood glucose levels prior to surgery. So class, take note, surgery is a stress on the part of the patient. And then one thing that is being done in the surgery is that the patient is placed on NPO. Okay, so imagine placing a diabetic patient on NPO. Your patient will be at risk for hypoglycemia, okay, because your patient is placed on NPO. So for that reason, class, if your patient is placed on NPO, usually they will be monitored for their blood sugar levels. Okay, you will notice diabetic patients on NPO are having blood sugar level monitoring 3 times a day. Okay, usually pre-meals. No, you don't have meals this time, so it's 3 times a day. And then class, their IV fluid would be containing D5. But then the thing there is that when their blood sugar will be increased, it needs to be lowered down. So we give insulin. If their blood sugar is low, we increase the rate of your D5 containing fluids. So it needs to be a balance between between the increase and the decrease of your insulin. Okay, we don't want very high insulin during surgery. Okay, we don't want also low insulin during surgery because your patient may have hypoglycemic coma related to that. Okay, so oftentimes these patients are managed with your insulin sliding scale. So when I say insulin sliding scale, okay, there's a certain range of glucose and then a certain amount of insulin that will be administered. So for example, if the insulin or the glucose level is 120 to 150, we give 2 units. If it is 150 to 180, we give 3 units. It's a 180 to 200, 4 units. And then above 200, we notify the physician. Okay, so there is an insulin sliding scale which is prescribed by the physician.
Then laboratories in glucose are being monitored. And then there needs to be vigilant nursing interventions for your patient. Okay, intraoperative phase. So again, there is a regular insulin with sliding scale. And then insulin should not be given intraoperatively. Okay, subcutaneous insulin, should not be given intraoperatively. Why? The absorption of this kind of insulin is affected by the temperature and then the circulatory blood volume. So during surgery, there may be decreased perfusion going towards the subcutaneous tissue of the patient. Okay, and then there may be anesthetics that will affect the patient. So it is not wise for us to administer subcutaneous insulin intraoperatively. Usually, we need to give your intravenous insulin for that matter. Okay, postoperative care, so you need to closely monitor the patient for their vital signs. You need to closely monitor the fluids and the electrolytes of the patient and then prevent wound infection. Your surgical site will be at high risk of infection, okay, because your patient's blood sugar may still be poorly controlled. Then you need to promote wound healing. So class promotion of wound healing could be attained if your patient would have proper dressing, okay, and then the dressing is done using your sterile technique. Okay, if it's not sterile class, you're increasing the risk of your patient for infection. Okay, take note of that. Now that will be all for diabetes. Our succeeding discussion will be focused already on thyroid problems, and then we'll be proceeding to adrenal problems. Class, thank you very much for your kind attention.